At the end of phaco-emulsification, in order to ensure adequate wound closure and a watertight seal, most of us resort to performing stromal hydration. Well, the procedure of stromal hydration consists of injecting fluid under considerable or at least minimal pressure into the tightly packed collagen stroma. This causes the swelling up of the stroma, it will cause the collapse of the tunnel, it will approximate the two lips of the tunnel. Once the lips of the tunnel are approximated, the dry collagen, which is intrinsically sticky in nature, will close and ensure watertight seal. Remember that the stromal hydration will last only for a few hours, maybe 3 to 6 hours, and while the stromal hydration is effective, it will work like a pressure cuff that approximates the lip of the clear corneal incision. Now, a clear corneal valved incision has a superior lip which is purely supportive in nature and it's pretty immobile. But more importantly, it is the inner lip which has a valved function. The inner corneal valved lip has an ability to move, and when the anterior chamber is pressurized, this valve will move up and seal the inner corneal lip. The tunnel, once it is approximated, will cling on or stick to each other because collagen in its natural dry state is very sticky. Now, how do we know this, that the corneal stroma is sticky? Is when we reposit the flap after a lasik surgery over a dry corneal bed. This flap can stick on without sutures. So using this concept, try to achieve a watertight sealing of the clear corneal incision without attempting stromal hydration. And for this, I just applied a cotton bud over the lip for a 20-second count. Now this is happening in real time. At the end of 20 seconds, fluid is very cautiously injected to a side port. This maneuver will cause the inner corneal valve to come up and seal. So I tested for watertight integrity of the wound by applying povidone drops and pressing on the surface of the cornea, and I found that the incision was holding quite well. Now the advantage is that you get a pristine incision without much distortion. Another example of the non-stromal hydration technique of sealing. So while applying the cotton bud, I noticed that the anterior chamber has collapsed. Now when the anterior chamber is not pressurized, the inner valve will not close, and therefore I inject a little amount of fluid, balance salt solution, through the side port incision. You can see that the cornea instantly reforms and the chamber gets pressurized and the valve completely seals. In fact, the valve was so efficient in this patient that the anterior chamber got a bit over pressurized, and I was forced to let out a little amount of balance salt solution in order to reduce the intraocular pressure. This technique, which I call the bud out technique, works about 60% of the time. The reason why it does not work in all cases is because there are differences in the way people construct the clear corneal incision, and there are differences in the corneal collagen content, the corneal hysteresis, and the behavior of the inner corneal valve. So sometimes when you find that you have applied the pressure and the wound is still leaking, you can try to inject balance salt solution through the side port in order to lift the inner corneal valve and make it seal. If you get adequate watertight closure with this, it's fine. But in case you still doubt the wound's integrity, then a small amount of hydrodissection, not the usual amount of fluid, but just minuscule amount of hydrodissection is enough to seal this incision shut. So you can try this because the lesser amount of stromal hydration is going to produce lesser distortion of the wound and a lesser risk of descemet membrane detachment. This idea was first put forward by my friend Dr. Jayaprasad of Amardeep Hospital. About 10 years ago, he described it He called it the ironing of the incision, and he advised it for wounds that do not seal following corneal burns.